Welcome. In this session, we'll be discussing about cystoid macular edema. Cystoid macular edema is a morphological diagnosis which can result from a large number of etiologies. Cystoid macular edema is accumulation of fluid within the neurosensory retina, located within honeycomb-like extracellular pockets called cysts, mostly in the outer plexiform layer and the inner nuclear layer of the retina. As seen here in this OCT, we show cysts in the outer plexiform layer as well as in the inner nuclear layer. CME causes loss of visual acuity and reduced contrast sensitivity. CME can also cause anatomical disruption of the cellular connections in the retina, and disruption of the inner layers of the retina can lead to the formation of an inner lamellar hole. Fluid may accumulate in the neurosensory retina due to disruption of the tight junctions between endothelial cells of the retinal capillaries, which is called the inner blood retinal barrier, the tight junctions between retinal pigment epithelial cells, which is called the outer blood retinal barrier, or disruption of the normal function of the retinal pigment epithelial cells, which is removing fluid from the neurosensory retina. The various etiologies which may lead to CME can be grouped into several categories. Vascular etiologies cause incompetence of the retinal blood vessels, which lead to fluid accumulation within the retina and include entities such as diabetic retinopathy, retinal venous occlusions, acute elevation of blood pressure, radiation retinopathy, retinal telangiectasias such as Coats disease and macular telangiectasia type 1, retinopathy of prematurity, and choroidal neovascularization. Inflammatory etiologies cause CME by production of pro-inflammatory factors such as prostaglandins, leukotrienes, and histamine, which increase the permeability of the retinal capillaries. And inflammatory causes of cystoid macular edema can be further subcategorized into post-operative cystoid macular edema, such as may follow cataract surgery, which is called Irvine-Gass syndrome, which we will be discussing in a little more detail later in this session. Laser procedures such as pan-retinal photocoagulation and Nd:YAG laser, cryotherapy, keratoplasty, vitrectomy, and scleral buckling, and uveitic causes of CME. CME can also be caused by certain drugs such as prostaglandin analogs, which we use topically to treat glaucoma, epinephrine, which we use intraocularly intraoperatively, and systemic drugs such as nicotinic acid, fingolimod, and glitazones. This OCT belongs to a patient with nicotinic acid-induced CME, which characteristically does not show any leakage on fluorescent angiogram. These photographs show bilateral CME from fingolimod therapy. CME can also occur in eyes with retinal dystrophies, and this is said to occur due to inadequate functioning of the retinal pigment epithelial pump, and these include retinitis pigmentosa, as seen here in this OCT and in this corresponding color photograph, Goldman-Favored syndrome, X-linked retinoschisis, guided atrophy, and dominantly inherited macular edema. Characteristically, CME from most of these retinal dystrophies do not show leakage on fluorescent angiography. Tractional causes of CME include epiretinal membrane, vitreomacular traction as seen here in this OCT, and myopic traction maculopathy. Other causes of CME include intraocular neoplasms such as choroidal melanoma and choroidal hemangioma, optic disc anomalies such as Pitt, coloboma, and morning glory syndrome, and CME can also occur within a detached retina. On clinical examination, we may be able to detect intraretinal cystic structures extending radially from the fovea, but this may be very subtle and difficult to detect clinically. Typically, these cysts are teardrop in shape, pointing towards the foveal center, as seen here in this fundus photograph taken by an OCT machine. Associated clinical findings include loss of foveal reflex, retinal thickening, subretinal fluid, optic disc edema, and signs of intraocular inflammation. OCT in an eye with CME shows increased retinal thickness, and OCT allows serial quantitative assessment of retinal thickness, which can be used to monitor response to treatment. Intraretinal cavities with reduced reflectivity, as seen here on this OCT, are the characteristic features of CME on OCT and is the most commonly used sign to detect the presence of CME. Hyperreflective signals due to lipid exudates within these cavities may also be found, as seen here in this OCT, and these may show motion signal on octa, which is called suspended particles in motion. In eyes with mild to moderate CME from vascular or inflammatory causes, fluid accumulates in the middle and outer layers of the retina as we have discussed. The outer layer is the outer plexiform layer and the middle layer is the inner nuclear layer. In severe CME, cysts may appear in the nerve fiber layer also. A central pocket of subretinal fluid called the cotton ball sign may also be seen in severe CME. In eyes with tractional schisis, the cysts appear predominantly in the outer retinal layers, and in eyes with posterior uveitis and neovascular AMD, a cystic space may appear due to separation of the myoid and ellipsoid zones of the inner segment of photoreceptors, and this is termed as bacillary detachment, as seen here in this OCT, with this layer representing the outer segment and the ellipsoid zone of the inner segment of the photoreceptors. Fluorescent angiography in an eye with CME shows progressively increasing hyperfluorescence throughout the angiogram, and in the early phase of the angiogram, this is due to decreased macular pigment density in an eye with CME, and also because of multiple small focal leaks from perifoveal capillaries as seen here in this angiogram. And in the later phases of the angiogram, there is accumulation of dye in cystic spaces around the fovea, and because of the orientation of the outer plexiform layer around the fovea, this hyperfluorescence from accumulation of dye within the cystic spaces takes up a petaloid shape as seen here in this angiogram, and this is very important to remember. Leakage from the optic disc can also be found in an eye with CME. As we have already mentioned, CME from certain causes do not show any leakage on fluorescent angiography, and this is very important to remember. And these include CME induced by drugs such as nicotinic acid and epinephrine, CME from retinal dystrophies such as retinitis pigmentosa and X-linked retinoschisis, and CME from tractional causes such as epiretinal membrane and vitreomacular traction syndrome. On fundus autofluorescence due to reduced density of macular pigment in an eye with CME, we will find hyperautofluorescence in the foveal region as a result of reduced blockage of autofluorescence from the underlying retinal pigment epithelium. The most commonly employed treatment modalities for CME include NSAIDs, steroids, and anti-VEGF. NSAIDs are typically used for CME following cataract surgery. Periocular and intravitreal steroids are typically used for CME from diabetic retinopathy, retinal vein occlusion, uveitis, and radiation retinopathy, and intravitreal anti-VEGF injections are used for CME due to diabetic retinopathy, retinal vein occlusion, choroidal neovascularization, radiation retinopathy, and from telangiectatic causes such as Coats disease, retinal arteriolar macroaneurysm, and macular telangiectasia type 1. We may note here that anti-VEGFs are not used for treating CME due to uveitis. Oral acetazolamide or topical dorzolamide can also be used to treat CME, particularly from that due to retinitis pigmentosa, and surgery is required for CME induced by epiretinal membrane and vitreomacular traction, and also for retinal detachment in which the detached retina may have cystoid macular edema, and laser photocoagulation is also indicated for Coats disease, macroaneurysms, macular telangiectasia type 1, and also for diabetic retinopathy, branch retinal vein occlusion, and radiation retinopathy. Cystoid macular edema following cataract surgery is called Irvine-Gass syndrome and occurs due to production of pro-inflammatory factors during and after cataract surgery such as prostaglandins and leukotrienes, which increase vascular permeability. And Irvine-Gass syndrome is the most common cause of vision loss after cataract surgery, and this is very important to remember. Angiographic CME or CME on fluorescent angiography occurs following 20% of uncomplicated cataract surgery, and visually significant CME or CME causing reduction in visual acuity occurs following 1 to 2% of uncomplicated cataract surgery. CME typically peaks 6 to 10 weeks after cataract surgery, and this is also very important to remember. So CME following uncomplicated cataract surgery is not found immediately following cataract surgery but occurs on average 2 months following the cataract surgery, and 95% of CME following uncomplicated cataract surgery resolves spontaneously within 3 to 12 months. Rarely CME may occur years after cataract surgery. following delayed rupture of the anterior vitreous face. Factors that increase the risk of Irvine-Gass syndrome are important, and they can be categorized into preoperative, intraoperative, and postoperative risk factors. Preoperative risk factors include diabetes with or without retinopathy. So risk of occurrence of CME following cataract surgery is increased in a patient with diabetes even without retinopathy. Retinal vein occlusion, uveitis, epiretinal membrane, vitreomacular traction, and a previous history of cystoid macular edema. Intraoperative risk factors include posterior capsular rupture with or without vitreous loss, iris manipulation, prolonged surgical time, retained lens fragments, and poor IOL positioning. And post-operative risk factors include inadequately controlled inflammation and hypotony. Management of Irvine-Gass syndrome includes topical NSAIDs, which can be used for both prophylaxis and therapy, and steroids, which can be administered topically, periocularly, or intravitreally. Combination of topical steroid and topical NSAID has been found to be superior to either drug alone, and this is important to remember. And topical therapy can take 3 to 6 months to resolve chronic CME, which may recur following cessation of therapy. And when CME does not resolve with topical therapy, periocular or intravitreal injections are considered. Surgery may be required to remove vitreous strands in the anterior segment and vitreous adherent to the macula, reposition a displaced IOL, or to remove retained lens fragments. Indiag laser can also be used to release vitreous strands in the anterior segment. Additional medications which may be beneficial in Irvine-Gass syndrome include acetosalamide and intravitreal anti-VEGF. To recap the salient points, cystoid macular edema is the intraretinal accumulation of fluid in extracellular pockets, particularly in the outer plexiform layer and the inner nuclear layer. Fluid accumulation occurs in the retina from either breakdown of inner or outer blood retinal barriers or from deficient functioning of the RPE pump. Etiology of CME can be vascular, inflammation, drugs, retinal dystrophies, traction, intraocular neoplasms, optic disc anomalies, and a detached retina. CME results in decrease in visual acuity and contrast sensitivity, and a long-standing CME may result in disruption of the cellular connections within the retina and formation of an inner lamellar hole. Ophthalmoscopic examination can show teardrop-shaped cysts surrounding the fovea in a petaloid pattern. Associated signs include retinal thickening, loss of foveal reflex, and intraocular inflammation. Fluorescent angiography shows punctate hyperfluorescent dots from leaking perifoveal capillaries in the early phase of the angiogram, followed by accumulation of dye within the cysts in the perifoveal zone, typically in a petaloid pattern. CME from drug toxicity, tractional etiologies, and retinal dystrophies typically do not show leakage on fluorescent angiography. OCT shows increased retinal thickness and hyporeflective cavities, mostly in the outer plexiform layer and the inner nuclear layer. Lipid exudates can show up as hyperreflective dots within the cystic spaces. Treatment of CME include topical NSAIDs, topical steroids, periocular and intravitreal steroids, oral acetazolamide or topical dorzolamide, intravitreal anti-VEGFs, and surgery for tractional causes. Irvine-Gass syndrome is the occurrence of CME following cataract surgery and is the most common cause of loss of vision following uncomplicated cataract surgery, occurring in 1 to 2% of cases. Its incidence peaks 6 to 10 weeks following surgery, and its risk factors include diabetes, retinal venous occlusions, uveitis, epiretinal membrane or vitreomacular traction, posterior capsular rupture, IOL malposition, and retained lens fragments. Treatment is similar to other causes of CME, but surgery may be required for vitreous strands in the anterior chamber, retained lens fragments, IOL malposition, and epiretinal membrane or vitreomacular traction. Thank you for listening.